All right. Welcome, everyone, to our 1 o'clock speaker, the one and only Dr. Radcliffe. I'm Vina, Glaucoma Marketing Manager, and I'll let Dr. Radcliffe speak to his accolades.
Thank you. Yes, I'm very good at introducing myself. Uh, but honestly, I have a nice experience with MicroPulse right from the beginning. I think a gentleman from Connecticut named Rob Noecker and I could debate which one of us was the first in the U.S. to do it, but this idea has been long in development, and I've now been using it well over a decade, I think. And I'm happy to share my experiences and take you through where we stand today with MicroPulse laser, some financial disclosures. Um, you know, uh, Glaucoma is just a challenging disease to manage overall. We have a couple things going on, driven mainly by OCT. We have earlier diagnosis, which is a wonderful thing, but people are living longer, so you now end up in these dilemmas where you have a young person you've diagnosed with disease, maybe even tried a few therapies, and they're still at risk for progressing with 40 years of lifespan on the horizon. So that creates the challenge. This is one thing we know about glaucoma. It's treating early and aggressively is the secret, because once it's a late stage disease, progression is inevitable. So you really have to be aggressive up front. I'll explain what MicroPulse is, but just sitting back from 10,000 feet, it's really the only non-incisional, non-tissue destructive, repeatable procedure for glaucoma that has surgical level of efficacy. It's titratable, it is repeatable, and it has a place for so many different types of patients, and this talk is just about the versatility of it as a treatment option, but I'll just explain a little bit about what's happening. This is just a nice little demonstration of how energy that is delivered in different ways can have different effects. Obviously, if you kept your finger under the candle, there'd be a burn, but you can get other biologic effects by pulsing the laser. So if you look at just this representation we think of continuous wave laser, how we do, for example, argon laser trabeculoplasty is just a long burst of energy, usually with a burning type of effect. Separating that into small pulses of energy can create a biologic effect without the tissue destruction, and that's what MicroPulse does. Has applications on the retina for diabetic macular edema, has applications in the trabecular meshwork for MicroPulse laser trabeculoplasty, but I'll be talking today about the laser used in the sort of transscleral approach. So this is the original generation of MicroPulse. This is the first probe that initially came out, and this is probably a 8-year-old video of mine. I did some initial research on my own case series, and we've had a lot to learn over the past decade in terms of how to deliver the energy. One of the biggest differences between in fact, is this your research? So my colleague happens to be here, Dr. Sarah Poor. This is our research looking at a series of patients. We followed most of them for 1 to 2 years after the treatment, and we use different laser power settings. And this is with a different probe, so it's not quite apples to apples when we talk about the modern Rev2 probe that we're using today. But we found that we got dramatic intraocular pressure reduction. People were maybe 26, often on Diamox, down to 15 millimeters of mercury. We were able to get the medications reduced over time, and we found that using higher levels of power resulted in a little bit more pressure reduction, but dramatic and lasting 1 to 2 years. So my first lesson for this laser is that if you have a treatment effect at 6 months or even 3 months, you're probably going to keep that. In my experience, a laser that is going to need to be repeated will reveal itself within the first 3 months of the treatment, sometimes even within the first month. So when you get a good effect and it lasts 3 to 6 months, you tend to keep that effect for the long term. And again, we just looked at different, even 1 to 2 years later, those who were treated with a higher power kept that effect. The mechanism of MicroPulse is fascinating, and there's probably more than just one. Initially with the sort of old school diode laser to the ciliary body, the mechanism was destruction of the ciliary tissue, and that would cause necrosis in the ciliary body. With MicroPulse, you see some increase in the, you don't see the necrosis, you don't see the tissue destruction or vascular destruction. What you can see is more space in the uveoscleral tissue, which is likely to help with uveoscleral outflow. That's one mechanism of MicroPulse. And this nice video from Murray Johnstone shows that you can also cause contraction here of the ciliary muscle, and that can cause opening of the angle. So there's a trabecular outflow potential mechanism in addition, and also a pilocarpine-like effect. So multiple mechanisms, from increased uveoscleral outflow, possible decrease in aqueous production, although it's almost a little questionable how much of that you're getting with this technique, and opening of the angle. So sort of a fascinating, novel way to get all these things accomplished without making an incision in the eye. So I just looked at this video. I just thought I'd start with a case. Every once in a while I get referred a patient for a trabecular outflow procedure, maybe a standalone MIGS, you might call it, a canaloplasty, goniotomy. And I'll feel that procedure may not get them enough pressure reduction, and so for me it's very natural to combine a procedure like that with a MicroPulse, as we're seeing in this video, although right now we're looking at my hand blocking the probe. But after performing the MicroPulse, if I want to do something in the trabecular meshwork, I can still go ahead and perform a canaloplasty, as you see here. And so, it's one of the procedures that can complement any other procedure if you're looking for added pressure reduction. And I would say that I use MicroPulse in combination quite frequently. Another common type of case for me might be a patient who had a tube shunt surgery 2 or 3 years ago, now has a cataract. I'll take the cataract out, and at that point it doesn't make sense to me to do much other than MicroPulse laser. I don't want to put more hardware in an eye that already has some. And we know from some of my work as well that MicroPulse can lower pressure very well in patients who already have a tube shunt in place. So it could be done before the tube shunt as an alternative to a tube shunt, but it can also help people lower the pressure once they've had a tube shunt. And that's a very common indication for MicroPulse, again, in my practice. Quite amazingly, we have hundreds of thousands of procedures performed worldwide, 28 different journals, 62 published clinical studies, and over 200,000 procedures performed. So it's quite a remarkable growth over the past few years, and I think I already talked a little bit about the differences between MicroPulse and continuous wave, but there are some meaningful differences from a clinical standpoint, and I'll just show you a little bit of data. The slow burn is sort of a halfway in between technique, not quite MicroPulse, not quite traditional laser, and that was invented by Dr. Gasterland. But generally speaking, you're getting good laser distribution with MicroPulse because of the way it's delivered in a sweeping fashion without causing this sort of focal coagulation of the tissue. And it's less thermal damage as well than the continuous wave laser. In my practice, I tend only to use MicroPulse because I just feel so comfortable with it, and I don't use continuous wave CPC laser, but I do have colleagues who will use CPC for more severe cases and MicroPulse for earlier cases, and I think the safety advantages of MicroPulse certainly support that approach. Again, if you were to disease stratify, you would use the CPC on your very severe patients and the MicroPulse on your earlier patients. The probe has been changed over the past few years, and this is a meaningful change. the most important thing is that the energy is now being delivered more posteriorly, more towards the pars plana, where we have that uveoscleral tissue, but not as much in the angle, not as much on the limbus, and the design of the new probe allows you to get that energy more posteriorly. Since I've switched to the new probe, I haven't had a single problem with a pupil changing its shape or becoming dilated, and I've had significantly less dryness, which sometimes was seen with the high energy MicroPulse delivered with the first generation probe, and that was probably from delivery that was just too anterior. So the new probe helps with optimal energy delivery to the right area of the eye, and it makes a big difference. So the laser basically allows you to adjust a few variables. It'll keep the duty cycle at 31.3%, which is the traditional number, and then you can vary the power, and you can vary the amount of time that you are giving the treatment for. There are different ways to kind of think about it. I go per hemisphere, so I might give an 80-second treatment to the superior hemisphere of the eye and an 80-second treatment to the inferior hemisphere. And we'll talk a little bit more about your sweep speed. So you can set this now with 20 seconds per sweep. And so that can help you pace out and be more consistent with your energy delivery. And that's one of the things that the consensus panel recently met and discussed, was being consistently slow with the delivery of the energy as we sweep around the eye. Power, now with the newer probe, usually set at about 2,500 milliwatts, and the number of sweeps. So here, this is going to be a 100-second treatment with 5 sweeps, 20 seconds each. So some nice ways to kind of keep track of the laser as you deliver. One end towards the limbus, the heel is towards the lid. That also helps you hold the lid open and get access to the eye. So I don't need a speculum when I do my laser at this point in time. And as I said, I think of my treatments per hemisphere. Some will think of treating a quadrant at a time. It's all just how you want to keep track of it, in your mind. So just some images of how we position the new foot plate on the eye, towards the limbus. And here's an example of a quadrant that is being swept, and looks like we're going for 5 seconds per quadrant, or maybe 10 seconds per sweep. And it's going to keep track of how many sweeps you've done, so you can have your treatment perfectly organized and ready to go. So, and part of the reason that we want to get our sweep sort of at the right speed is to get the temperature and the amount of biological activity at the right place. Some other advances in the way we deliver the MicroPulse have been to use a coupling agent. So that's just something like either like a genteel gel, perhaps some Provisc, viscoelastic on the surface of the eye that will help distribute the laser. And that's been a great advance. You could use lidocaine gel if you want. Lid speculum is at the discretion of the treating surgeon, orienting the probe correctly, applying a good amount of pressure, and the pressure really does make a difference in terms of the laser energy uptake, and you want to have firm pressure, flush with the tissue, blanching blood vessels, for example, pressing hard enough to do that, but not so hard that you're going to tear the conjunctiva or significantly depress the eye. And using a microscope is a nice way to do the procedure, but it can be done with a pair of reading glasses. I've done it with an indirect ophthalmoscope in my office, so loupes would work as well. So you do the MicroPulse procedure in a variety of settings. Most of mine are done in my ASC, but not in the operating room, in the laser room of my ASC. And we'll block the patient. I have a fantastic anesthesiologist who's done over maybe 150,000 retrobulbar blocks in his career. He's really experienced, and he'll do the blocks for me. So the patient comes in blocked, but you can use a peribulbar block if you're in your office delivering the block yourself. Sedation is optional, I find, and the one thing that to me is not optional is the delivery of a steroid. usually subconjunctival dexamethasone after the application of the laser. This rule, I think, applies to every surgery we do, but particularly with MicroPulse, is that if you treat at the time and you get ahead of the inflammation goes away very quickly within a week with just pred 4 times a day. No need to taper beyond that. If you miss that opportunity to get ahead of the inflammation and the patient is very inflamed day 1, you could play catch up for weeks or months. So very easy, just give subconj dex at the time of the procedure and the patient will do great in terms of inflammation. And we avoid the tube shunt spot and other areas with heavy pigment, for example, or hemorrhaging. I was part of a consensus panel of very experienced MicroPulse surgeons, and Rob Noecker and Tom Grippo led the panel. And we got together and really just talked through what we think the best practices are. We reviewed the literature. We wrote a few manuscripts on our process of how we think the laser works, what the best evidence is, how it should be dosed, and looked into a few different things. Recommendations on who could have the procedure, starting with patients who, for some reason, aren't suitable for incisional glaucoma surgery. Could be someone who had it in their other eye and didn't have a great response, someone who had a complication. I have many patients who've had family members treated elsewhere who've gone blind from glaucoma surgery, according to the patient. Never going to be able to find out what really happened there, but I can offer them an alternative and that's appealing to patients. As I mentioned earlier, I do a lot of OMIDs, about 300 OMID valves a year, and many of those fail. Maybe that makes about 60 a year that won't get perfect IOP control, where a MicroPulse can be very helpful. There are patients maybe who, for some other reason, have uncontrolled pressure but can't have a tube shunt. Someone who's traveling in the near future wouldn't be a good idea to travel with a fresh OMID valve or something like that. MicroPulse can be done that day. They can get on a plane that night, as far as I'm concerned. It's just that safe to travel afterwards. And then there are patients who are just on too many medications. They're getting toxic. Maybe they're on a Rho kinase inhibitor. Their eyes getting very hyperemic. MicroPulse can be a tool to help people reduce their eye drop burden and have a better quality of life from that standpoint. Really the key is it's just a versatile treatment that can be used in a variety of sequences. Certainly when you get into some of the more atypical glaucomas, angle closure glaucoma, and then a variety of secondary glaucomas, it can be used on any type of glaucoma. I happen to work with a ocular oncologist who has a lot of eyes with cancer in them, most of whom have been treated. But in many cases, when there's an active cancer in an eye, you don't want to put a tube shunt in where you could spread the cancer. MicroPulse is just a remarkable treatment in that challenging situation, because you don't have to enter the eye. There's no risk of spreading a cancer. Here's a patient. Apologize for the dry cornea. And again, this is with the first probe here. But it was a patient who did not want to have traditional glaucoma surgery, had a CyPass. So you can actually see the CyPasses right there. So this is after MIGS. And again, wanted an angle procedure. So we did a canaloplasty with a 360-degree ab interno goniotomy, and then also finished that up with MicroPulse. And this was a neat procedure, because there are not too many times where I've put a catheter through the canal of Schlemm with a hydrus or a CyPass sitting in the angle, but that's exactly what we did in this case, and the patient did very well. This is my dexamethasone that I use, post-operatively to control inflammation. It is 4 milligrams that's delivered, and it's, I don't use triamcinolone as much. I use a lot of Trimoxy in the operating room for cataract surgery, which has triamcinolone. It probably lasts a little too long for MicroPulse. I don't think you need triamcinolone. Dexamethasone seems to be great. Solumedrol will be fine, something short-acting, because you just get them controlled that day. here are some starting parameters for your treatments, and I actually put a severe in here. But generally speaking, with the new probe, you're going to use 2,500 milliwatts. With the older probe, that was the equivalent of about 2,000 milliwatts. Remember, we're delivering the energy more posteriorly now, and we're delivering energy more in like the pars plana and a little pars plicata, but not so anteriorly, so we're using a little more energy with the new probe. 20-second slow sweeps per hemisphere for me, and I'll do between 3 and 4 sweeps, so 80 to 90 seconds of a treatment, you know, that's a classic protocol for me. Things like the patient being on Diamox will make me use a higher setting or longer duration of treatment. Patients with poorer vision, hand motion, I'll use higher energy settings. Patients with a lot of pigment in their skin will cause me to use a little less because they'll have a more pigmented ciliary body, and they'll absorb the laser energy. So I can go down on the setting if they have more pigment just generally present in their body. Reimbursements have been an interesting topic as of late, and I would say it's not quite as interesting for MicroPulse as it has been for the rest of MIGS, particularly goniotomy and canaloplasty. But let's see what I can tell you about that story. You know, the CPT code is 66710, and that is the cyclophotocoagulation code. There's a separate endoscopic photocoagulation code that's different, and that's now been bundled with cataract surgery in some circumstances. This code is still its own independent code. It has a 90-day global period, and the reimbursement is sufficient to do the procedure either in the office or in the ASC. But the ASC is probably a healthier place to do it because you'll get reimbursed an additional amount for the probe as well. WPS is a Medicare administrator, and they just put out a LCD, which is a local coverage determination, and they designated MicroPulse as refractory, so treatment for refractory glaucoma. And you know, my analysis of this is that this has been the indication according to the payers for many years, right? It's never had an early indication. It's just been used early by surgeons who found that it's a safe and effective treatment. I don't think this has any big changes for us at present. I do think occasionally the insurers will try to give us a hard time about treatment, but that traditionally hasn't been the case due to MicroPulse being used in more reasonable volumes. The problem with goniotomy is that it went from being performed something like 500 times a year nationally, back in the year 2010, to being used 400,000 times annually. It's really that much of an increase, and so that's what's led to the LCD policy changes. My prediction is that we won't see any difference in the actual reimbursement or the ability to get this procedure performed, even in mild or moderate glaucoma. You may need to take a moment in your chart to just indicate why you're performing the procedure, which I think most of us do anyway. But for me, if I had a mild glaucoma patient who couldn't tolerate 3 different classes of medications, I would just document that, explain that patient has too mild disease to justify a tube shunt, and MicroPulse is the only therapy that can be efficacious enough to replace the drops, and I don't see why I would have any reason getting that procedure performed. So I think it's going to be the same level of reimbursement as far as I see it, even with this new LCD determination, and I see most of the attention being focused on goniotomy and canaloplasty due to their higher utilization. One day I just put together a list of different types of patients where I've done MicroPulse, and the patients prefer laser therapies, generally speaking. For elderly patients, you have a bunch of different problems. They may have trouble getting post-op drops in their eyes. They may be at a higher risk of fall, which can be more devastating if they've had a glaucoma surgery. and maybe they had a serious complication in their fellow eye, maybe they've had a tube shunt that's not working. Once they have poor vision, it doesn't make as much sense to do a surgery like a tube shunt. Blepharitis is a risk for infection. As I mentioned, eye cancer, risk of falling. Even things like patients who just can't come to the operating room proper because they don't have someone to take them home could have a laser and then be brought home in your clinic later that day. And there's a retina doctor who sends me all sorts of patients that need MicroPulse. Yep. Thanks, Dr. Scheinlin. And so retina neovascular cases, not uncommon to need to do some MicroPulse in those eyes. And often the retina doctor will request that specifically rather than a tube shunt. And all these different ones. And then finally, emergencies. This is one of the few procedures where you can really deliver the type of surgical efficacy you would get from a trabeculectomy or a tube shunt 10 minutes after meeting the patient. And I had just such a case. It's Friday afternoon. I had a patient come in, pressure is very elevated, they're at risk of losing vision. And we talked through the process of, okay, you could go to the emergency room, they'll run some lab tests, they'll try to get an OR for you, but it's not gonna happen on a Friday night in New York City because there's like 3 gunshot wounds that just came in. So we'll do the surgery tomorrow morning, or I can numb your eye here in the office right now. You can have a 2-minute treatment, something like that, 2 minutes of laser time. And you'll be leaving the office a half hour from now with your eye patched and this problem has been treated. And it's just remarkable. And the question I'll often get is, almost like, why do you ever do anything other than this? And it's a reasonable question, and we all have our sort of habits and ways we've been trained. But MicroPulse is just a remarkably reliable treatment. Here are all the side effects that have ever been observed. But I would also tell you that most of this, in my impression, is from traditional cyclophotocoagulation. Things like ptysis, things like the limbal stem cell damage, the pupillary change, loss of accommodation. For me, only with either traditional MicroPulse or Generation 1 probe. I haven't seen any of that with the new probe. Generally speaking, in terms of side effects, I get a little bit of inflammation that I treat with a topical steroid and the subconjunctival dexamethasone. I will occasionally see some dry eye, but not the limbal stem cell damage that I've seen previously with other versions of cyclophotocoagulation. Our consensus panel thought we should be cautious in eyes with scleral thinning. Uveitis, I have to say, I use MicroPulse fairly frequently in uveitis. I haven't found the uveitis to worsen consistently. I know that sounds paradoxical, and I wouldn't have said that unless I just had a decade of experience where it didn't make uveitis worse in my uveitic patients, where this seemed like the most reasonable option. Usually they're controlled eyes, but still with a diagnosis of uveitis. Active uveitis, I would be cautious. So I'll summarize that 10 years plus of MicroPulse, and it's just been a fantastic addition. I heard a colleague of mine recently say that this laser is really an indispensable tool to those of us managing glaucoma, and it's true. I just couldn't practice without it today. The long-term efficacy is established, a variety of patient types. It's versatile and titratable. Different stages of glaucoma can be addressed. And understanding your sweep speed, your laser settings are the keys to success. Controlling the inflammation is important as well. But ultimately, it's all about titrating the right dose of laser to the patient to fit their individual needs. And it's amazing that we have treatments where we can take each patient and give them their own specialized, customized treatment. Happy to take any questions. Thank you.
Thank you, Dr. Radcliffe.
Just 2 quick ones. You said peribulbar blocks. When I've done peribulbar and I get sometimes chemosis,
Yep.
which affects outcomes, has that been a problem?
You can do this laser with subconjunctival chemosis as long as it's clear fluid, but If your anesthesia migrates forward and the patient gets, a bullous conjunctiva, you're just simply going to depress until you feel the firm sclera underneath and then give the
So
treatment.
not a contraindication. Okay, great. Second question is, how often do you repeat it?
I don't repeat it too frequently, but if I were going to repeat it, in other words, sometimes I'll have a patient where, I'll say, listen, I want to be one eye, I want to be super careful. I'm going to use a lower laser setting, and I'm going to give us a 50% chance of repeating it. And then I go and I do my lower setting. I would probably pick about 2 months as the time to give the second treatment, and I would probably, it'd be rare for me to repeat it within a month. So, I would try to give it some time to have its full effect.
Thanks.
Yep. Yeah, but I don't think I repeat more than 10% of my lasers. If that's another way you may have been asking that question. Yeah.
Yeah, so let's say that the typical drop in IOP is 30% or whatever, to
Yep.
pick a number. My question is, how soon after the treatment
Yep.
does it get there? Does it take a week, 2 weeks, 3 weeks?
Often I'll see them 1 week after. I don't see them 1 day after. I would tell you it's almost never down 1 day after.
But a week you would
week,
see?
yeah, a week you'll see a response.
Yeah, a friend who had sudden spike in IOP was told, actually by the Glaucoma Center here, well, we could do TLT, but we wouldn't know for 4 weeks or 8 weeks whether it had worked, and so we have to put in a valve of some kind.
Yeah. Now, and I would say some of my patients are on Diamox when I do the laser, and what typically I'll see is like a pressure of 8 or something at 1 week, and then I stop the Diamox, they come up to 12 or 13, and then we know we've got a good treatment effect from that.
Well, but in that case, it went down too much.
Well, they stayed on the Diamox.
Right. But in terms of if that doesn't happen, then if it's going to drop by 30%, you say you'll see 90% of that within the first week.
Yep.
Thank you.
And you will occasionally see a little bit more IOP reduction at 1 week than you're going to keep in the long run. So they can go to 10 and then back up to 14 or 12. Some of that may be the medicine washout effect too, because even if you stop all these meds on the day of the laser, they're going to have a little effect for a few more days. I've never seen hypotony or choroidals from MicroPulse alone as a surgical complication. I have seen hypotony when I've combined the Ahmed valve with MicroPulse, and I think that's because I caused that little bit of inflammation in the suprachoroidal space, that's part of its mechanism, at a time when the Ahmed valve created hypotony, and then it makes sense to me that you would get a little bit of an exaggerated choroidal response there.
When you're doing a post valve, and you say you don't do it in the quadrant of the valve, do you mean just right where the tube inserts? Like on either side of it? You don't. You can still do the rest of the angle.
80% of that quadrant is still treated. I don't treat over the tube, and I don't want to treat the conj that. I don't want the laser energy hitting the conj that's like within a millimeter of my tube, and that is because I've certainly seen a lot of eyes that have had both tubes and MicroPulse and tube erosions. Now those are just by virtue of the fact that they've had a tube and MicroPulse, they're pretty bad glaucoma eyes. I mean, that's two treatments there, and they've all been on drops for decades. So I don't know if the MicroPulse is a contributor to that specifically, or if it's just that it's a coincidence. I have plenty of eyes with 2 tubes, no MicroPulse, that erode, and it's the same type of thing. Many years of meds and all that. Yeah.
So you're not worried about the pericardium being,
I doubt that. I doubt you get great penetration through the pericardium, but I'll still treat through that. Yeah, it won't hurt the pericardium. No.
Right, but you think you may be able to get something through it.
Yeah.
One other question. Escape me.
Now take your time.
When you're doing the when I do transscleral, I try to avoid the 9 o'clock and 3 o'clock position. How about with this?
Since I've switched to, and that was one of the things we recommended as a consensus panel, but since I've switched to the Rev 2, I don't feel as strongly about that anymore. I think when we were treating very anteriorly and you hit the dead, 3 o'clock and 9 o'clock, you'd hit that neurovascular bundle, you get some pupil changes. But now that we're treating so far posteriorly, I'm just not seeing that as a side effect. So I don't harp on that area for a really long time, but I still treat 6 and 9, and it's typically where I'll come down, linger for a moment, and then start making my sweep back the other way. But I want to cover the whole eye if I can, at least with a little bit of energy. Yeah.
Any other questions? All right. Thank you.
Thank you.